Now continuing with the lab diagnosis of influenza virus, specimen collection. Ideal specimen are nasopharyngeal swab or lavage fluid, nasal aspirate or to a less extent the throat swab. Swabs with a synthetic tip, example polyester or dacron, are the best for specimen collection. Cotton or alginate swabs are unsatisfactory. Transport swabs are immediately put inside the viral transport media, kept at 4 degrees Celsius during transport up to 4 days, thereafter at minus 70 degrees Celsius. Isolation of virus. Embryonated eggs, amniotic cavity, and primary monkey kidney cell lines have been the methods of choice for the isolation of influenza virus in the past. The viral growth in cell line was detected by hemadsorption or hemagglutination test. Because of technical difficulty, isolation is not routinely performed for diagnostic purposes. Direct immunofluorescence test of viral antigens coated onto epithelial cells can be directly detected in nasal aspirate by using fluorescent tagged antibodies. This is rapid but less sensitive than viral isolation. Molecular methods. Molecular methods have revolutionized the diagnosis of influenza. RT-PCR, reverse transcriptase, polymerase chain reaction. It is highly sensitive, specific, and rapid. uh, Turnaround time of less than a day. It can also detect the specific type and subtype of influenza virus. This is the viral transport medium and a swab inside that. Okay. This is RT-PCR graphs. A to D, it shows A shows H1N1, A oblique H1N1 growth. The figure B shows A oblique H3N2 growth. Figure C shows type B influenza, and the figure D shows a negative result. Okay, so in the real-time PCR reports simultaneously detects 5 genes. Influenza A, if present, it is present in A oblique H1N1 and A oblique H3N2. In H1N1, HA gene is present in H1N1. H3N2, HA gene is present in H3N2 type. Influenza B gene is present in type B, and RNP, ribonucleoprotein gene, is present in all the types. Okay, H1N1, AH3N2 type B, and influenza negative also. RNP is ribonucleoprotein used as internal control in real-time PCR. If this is not detected, then the test is considered invalid. So that's it. In real-time PCR, the currently gold standard method for influenza diagnosis. It is quantitative, has higher sensitivity and specificity than RT-PCR with a turnaround time of 2 to 3 hours. It simultaneously detects the 3 common seasonal flu strains: A oblique H1N1, A oblique H3N2, and type B. The result is expressed as the emission of fluorescence during the cycles as described in figures. Biofield Married Respiratory Panel (RP) test are simultaneously 20 respiratory pathogens, including influenza A oblique H1, influenza A oblique H3, influenza A oblique H1 2009, and influenza B. Antibody detection serology. Various assays are available to detect subtype specific serum antibodies by using specific influenza antigens. It is mainly useful for seroepidemiology purpose, not for clinical diagnosis, as antibodies may be present in normal individuals. The tests available are ELISA, neutralization test, and previously used HAI, hemagglutination inhibition test. Treatment of influenza. Specific antiviral therapies available for influenza virus infection. Start therapy within 48 hours of onset of symptoms for influenza. Neuraminidase inhibitors such as zanamivir, oseltamivir, and paramyxoviridae can be administered for influenza A and influenza B infections. It is a drug of choice for A oblique H1N1 2009 flu, A oblique H5N1 avian flu, and influenza B. Dosage: oseltamivir, Tamiflu 75 mg tablets, and zanamivir 10 mg inhalational form. Schedule for treatment given twice a day for 5 days. For chemoprophylaxis given once daily. Duration depends on the clinical setting, usually 7 days. Matrix protein M2 inhibitors such as amantadine and rimantadine can be given for some of the strains of influenza A infection. However, strains of A oblique H1N1 2009 flu and A oblique H5N1 avian flu and influenza type B virus have developed resistance for the same. Now, the general preventive measures of droplet precaution should be followed. Strict hand hygiene, isolation room. Patients should be kept in isolation room, or cohorting is to be followed. Containment of coughs and sneezes. Respiratory hygiene and cough etiquette should be followed. Use of personal protective equipment such as gloves, 3-ply mask, gown, and goggles for healthcare worker. Patient should wear a mask. Work restrictions, CDC recommends that people with influenza-like illness remain at home until at least 24 hours after they are free of fever more than 100 degree Fahrenheit without the use of fever-reducing medications. Vaccine prophylaxis, vaccine strains. Based on WHO recommendation, influenza virus are prepared every year. Influenza vaccines are prepared every year. Strains to be included in the vaccine depend upon the strains isolated in the previous influenza seasons and the strains that are anticipated to circulate in the upcoming season. Formulations: influenza vaccines are available in cocktail of either 3 strains or 4 strains. Trivalent form comprises of 3 strain A/H1N1, A/H3N2 and influenza type B strain. Quadrivalent form comprises of 4 strain A/H1N1, A/H3N3 and 2 lineage of influenza B strain. Now the composition lineages of A/H1N1, A/H3N2 and influenza type B strain included in vaccine change every year. The lineages included in vaccine are different for northern and southern hemispheres. WHO constantly reviews the vaccine composition and decides on which lineages to be included in vaccine every year. Types: both injectable, inactivated and nasal spray live attenuated vaccine are available. Injectable vaccine are most widely used vaccine in immunization programs. There are 3 types of injectable vaccine: inactivated influenza vaccine (IIV), example Fluzone, prepared by growing the vaccine strains in embryonated chick eggs, then harvested, purified and inactivated and then standardized to contain 15 microgram of HA per dose. Cell culture based inactivated influenza vaccine CC second V3, example Flucilvax, same as IIV but prepared in cell lines such as Mandan, Darby, canine, kidney and CDK cell line. Okay. Recombinant influenza vaccine RIV, example Flublok, contains recombinant influenza HA antigens in trivalent or quadrivalent formulations. RIV does not contain any egg protein. Schedule: single dose administered by intramuscular IM route except for 6 months to 8 years of age. 2 doses are required more than equal to 4 weeks apart. Timing of vaccination: optimally before onset of influenza season, that is by the end of October. Efficacy: the vaccine efficacy varies from 25 to 67%, 25% for H3N2, 42% against type B and 67% against H1N1. The efficacy is lower if vaccine virus does not match to currently circulating viruses in the locality. Immunity lasts for 6 to 12 months. Side effects: mild reactions can occur in 5% of the cases such as redness at injection sites, fever and aches. Serious side effects such as allergic reactions can occur very rarely. Indication: routine annual influenza vaccine is recommended for all persons aged more than equal to 6 months who do not have contraindications. If not feasible, then high risk groups should be given first priority for vaccination. High risk group individuals, they are common. Contraindication: IIV should not be administered to people who have a history of severe allergic reaction to previous dose of vaccine. In patients with egg allergy, vaccine can be given but under supervision. Travelers: if traveling to an area of increased influenza activity, can consider vaccination preferably more than equal to 2 weeks before departure. Now the live attenuated vaccine LAIV. Live attenuated vaccine is generated by resortment between currently circulating strains of influenza A and B virus with a cold adapted attenuated master strain which is adapted to grow at 25 to 33 degrees Celsius. Such live attenuated strains can grow in upper respiratory tract at 33 degrees Celsius but not in lower respiratory tract at 37 degrees Celsius. Therefore, they may cause mild flu-like symptoms but never infect the lower respiratory tract, hence never cause serious adverse effects. It is a trivalent vaccine administered by intranasal spray. Indication: it can be given to all healthy persons of 2 to 49 years of age except in pregnancy but not given to high risk groups. Chemoprophylaxis. Antiviral drugs are not recommended for routine seasonal or pre-exposure prophylaxis. It is recommended only for post-exposure and during outbreak situations in hospitals. Indications: following exposure to an influenza case, it is recommended to the following groups: if not vaccinated or vaccinated recently, less than 2 weeks, or second, HIV infected people. Duration: non-outbreak exposure, example in community, it should be started as soon as possible following exposure within 48 hours and continued for 7 days. During outbreaks in hospitals for elderly persons, children, and healthcare workers, duration for a minimum of 2 weeks and to be continued up to 1 week after the last known case was identified. Antiviral drugs recommended are oseltamivir is the drug of choice. It is given as 75 mg orally once a day for 7 days, and zanamivir 10 mg to 5 mg inhalations once daily for 7 days. Efficacy of chemoprophylaxis is about 70 to 90% in preventing influenza. So this completes our Orthomyxoviridae family. Now coming on to the paramyxoviridae infections. Paramyxoviridae contains a group of virus which are transmitted via the respiratory route of infection, following which they may cause localized respiratory infection in children. Example: respiratory syncytial virus, metapneumovirus, and parainfluenza virus. Or they may disseminate throughout the body to cause highly contagious disease of childhood such as mumps, parotid enlargement, and measles. Paramyxovirus resemble the orthomyxovirus in morphology, but they differ by the following properties. They are larger, 100 to 300 nm in size, and more pleomorphic, and possess linear non-segmental RNA compared to the segmental RNA of the influenza virus. Now, this is the schematic diagram of paramyxovirus, the measles virus. It has a fusion protein HA, then it has a matrix. Inside there is the nucleocapsid. On the outer layer, there is a lipid layer of envelope, and inside the a non-segmented RNA is also present. It contains 6 structural proteins compared to 8 in the influenza virus. HA and NA antigens. The paramyxovirus vary from each other in the expression of HA and NA antigens. Parainfluenza and mumps possess both HA and NA antigens similar to the influenza virus, while measles possess HA but lacks NA. RSV and metapneumovirus lack both HA and NA antigens. Now there are few zoonotic paramyxoviruses such as Nipah and Hendra virus which can occasionally infect humans also. Now the parainfluenza virus. Human parainfluenza virus are one of the major causes of lower respiratory tract disease in young children. They have 5 serotypes. Type 1 and 3 belong to genus Respirovirus, and type 2, 4A and 4B belong to genus Rubella virus. Okay. Clinical manifestation: transmission is by respiratory route, by direct salivary contact, or by large droplet aerosols. The incubation period appears to be 5 to 6 days. Virus multiplies locally and causes various respiratory manifestations such as mild common cold syndrome like rhinitis and pharyngitis are the most common presentation seen with all serotypes. Croup laryngotracheobronchitis occurs in 2 to 3% of the cases, typically seen with type 1 and 2, involves children between 6 to 18 months of age. Pneumonia bronchiolitis occurs very rarely, seen especially with serotype 3, involves infant below 6 months of age. Otitis media is the most common complication of parainfluenza virus infection. Reinfection are common but less severe. There is no cross protection between the serotypes. Epidemiology. Parainfluenza virus are worldwide in distribution. Type 3 is the most prevalent serotype. It exists as endemic throughout the year, and annual epidemics occur during the spring. Types 1 and 2 infection are less common and seasonal and tend to cause epidemics during the rainfall or winter, cyclically every alternate year. Type 4A and 4B cause much milder illness, and these serotypes are the most difficult to be isolated. Parainfluenza virus are important cause of outbreaks in pediatric wards, daycare centers, and in schools. Lab diagnosis. Antigen detection. Viral antigen in the infected exfoliated epithelial cells of the nasopharynx can be detected by direct immunofluorescence test by using specific monoclonal antibodies. It is rapid but less sensitive than viral isolation. Viral isolation. Specimens such as nasal washes, bronchoalveolar lavage fluid, and lung tissue can be used. Primary monkey kidney cell line is most sensitive, and alternatively, a continuous monkey kidney cell line LLC MK2 can be used. They produce little or no cytopathic effect. Viral growth can be detected by demonstration of antigen by direct immunofluorescence test. Shell viral technique is followed to enhance viral replication. Serum antibodies can be measured by neutralization test, HAI test, or ELISA. Presence of IgM or fold-fold rise of IgG titer is indicative of an active infection. Reverse transcriptase PCR assays are highly specific and sensitive but available only in limited settings. Biofire film array respiratory panel test. Simultaneously, 20 respiratory pathogens are detected, including parainfluenza serotypes as well. Now, the animal parainfluenza virus. Certain animal parainfluenza virus are related to the human strains. Sendai virus of mice is a subtype of human parainfluenza virus type 1. SV type, a common contaminant of primary monkey kidney cell lines, is related to parainfluenza virus type 2. Shipping fever virus of cattle and sheep SF4 is a subtype of parainfluenza virus type 3. Avian parainfluenza virus, Newcastle disease virus or NDV. NDV, also called as Ranikhet virus in India, produces pneumoencephalitis in young chickens and mild flu-like illness in older birds. Human infection is rare and occupational, characterized by self-limiting conjunctivitis that may occur in workers handling infected birds. So this completes parainfluenza virus. Now coming on to mumps. Mumps virus is the most common cause of parotid gland enlargement in children. In severe cases, it can also cause orchitis and septic meningitis. Pathogenesis. Transmission is through the respiratory route via droplets, saliva and fomites. Primary replication occurs in the nasal mucosa or upper respiratory mucosa, infects mononuclear cells and regional lymph nodes, spills over the bloodstream resulting in viremia, which causes dissemination. Target sites. Mumps virus has a special affinity for glandular epithelium. The classical site includes salivary gland, testes, pancreas, ovary, mammary gland and central nervous system. Clinical manifestation. Incubation period is about 19 days, ranges 7 to 23 days. In apparent infection, up to half of the infected people are either asymptomatic or present with non-specific symptoms such as fever, myalgia and anorexia. This is more common in adults than in children. Bilateral parotitis, acute non-suppurative parotid gland enlargement, is the most common specific manifestation, present in 70 to 90% of the cases. Rarely, parotitis may be unilateral. In some cases, other salivary glands may also be involved. In this figure, we can see the parotitis in mumps infected patients. Okay. Now, epididymoarchitis is the next most common manifestation of mumps, developing in 15 to 30% of the cases in post-pubertal males. Orchitis is unilateral in most of the cases, hence infertility following mumps orchitis is rare. Aseptic meningitis occurs in less than 10% of the cases with a male predominance. It is self-limiting condition except the deafness due to cranial nerve palsy, which may be permanent. Ophoritis occurs in about 5% of women. Pancreatitis occurs in about 4% of infections and may lead to diabetes. Atypical mumps parotitis may be absent in 10% of the cases and patients directly present with aseptic meningitis. Now the epidemiology. Mumps is endemic worldwide, sporadic case occurring throughout the year with a peak in cases typically in winter and spring. Epidemics occur every 3 to 5 years, typically associated with unvaccinated people living in overcrowded areas. Period of communicability. Patients are infectious from 1 week before to 1 week after the onset of symptoms. The most contagious period is within 1 to 2 days before the onset of symptoms. Infective material. Mumps virus is shed in saliva, respiratory droplets and urine. Source. Cases, both clinical and subclinical cases, are the source of infection. There is no carrier state. Subclinical cases, 30 to 40% of all cases, are responsible for maintaining this cycle of infection. Reservoir. Humans are the only reservoir of infection. Incidence. About 5 lakh cases of mumps occur every year globally. 4,99,512 cases in 2019 WHO report. The number of cases have been reduced after the start of immunization. Children of 5 to 9 years of age are most commonly affected. However, no age is exempt if there is no previous immunity. The disease tends to be more severe in adults. Immunity. One attack either by vaccine or infection gives lifelong immunity. The secondary attack rate is high, 86%. Now coming on to the lab diagnosis of mumps. Specimen is buccal or oral swab. Antigen detection is by direct immunofluorescence test. Viral isolation by using primary monkey kidney cell line or by shell vial technique. Serum antibodies by ELISA and neutralization test. HAI test on RT-PCR detects viral RNA. Now lab diagnosis. Specimen. The buccal or oral swab specimen are most ideal specimens, although mumps virus can also be detected in saliva, CSF and urine. They are shed up to weeks, seminal fluid and rarely blood. Massaging the parotid gland area for 30 seconds prior to swabbing is recommended. Direct viral antigen detection can be done by using mumps-specific immunofluorescence staining. Direct immunofluorescence of clinical specimens. Virus isolation. Monkey kidney cells are the preferred cell line. Specimens should be inoculated immediately. Viral growth after 1 to 2 weeks can be detected by demonstration of cytopathic effects, cell rounding, and giant cell formation or heme adsorption. The shell vial technique is followed for rapid detection in 1 to 2 days. Serum antibody detection and ELISA is the most widely used assay which detects antibodies against mumps, specific whole virus antigen, nucleoprotein, and hemagglutinin antigens. Mumps ELISA is highly specific, does not cross react with parainfluenza antibodies. Reverse transcription PCR is available to detect mumps specific RNA such as NG nucleoprotein in clinical specimen. It is highly sensitive and specific. Now, the treatment of mumps, there is no specific antiviral drug available. Treatment is mostly symptomatic. Mumps, immunoglobulin is available but not effective, hence not recommended for treatment or post-exposure prophylaxis. Now, prevention, live attenuated vaccine strain, live attenuated Geril line strain is recommended strain for use worldwide. Mumps vaccine is prepared in chick embryo cell line. Mumps vaccine is available as trivalent MMR vaccine, live attenuated measles, mumps, rubella vaccine, or quadrivalent MMR-V vaccine contains additional live attenuated varicella vaccine. Monovalent mumps vaccine not commonly used. Schedule: 2 doses of MMR is given by subcutaneous route at 1 year, 12 to 15 months, and 4 to 6 years before starting of school. Efficacy is about 88% after the second dose. Neutralizing antibodies appear in 95% of the recipients. The duration of long-term immunity is unknown. Now, the respiratory syncytial virus infection. Respiratory syncytial virus is a major respiratory pathogen of young children and is the most common cause of lower respiratory disease, bronchiolitis, and pneumonia in infants. Pathogenesis: transmission of RSV is spread by direct contact, contaminated fingers of fomites, or by self-inoculation onto the conjunctiva or anterior nares, or by large droplet inhalation. Spread: RSV replicates locally in the epithelial cells of the nasopharynx and may spread to the lower respiratory tract to cause bronchiolitis and pneumonia. Clinical manifestation: RSV causes a wide spectrum of respiratory illnesses. Incubation period is about 3 to 5 days. Infants, RSV is the most common cause of lower respiratory tract infection below 1 year of age, causing bronchiolitis, pneumonia, and tracheobronchitis in 25 to 40% of infected infants. Symptoms: it begins with running nose, fever, and accompanied by cough, wheezing, and dyspnea. Chest X-ray shows peribronchial thickening, diffuse interstitial infiltration, and occasionally lobar consolidation. Infection is severe in premature infants and underlying congenital cardiac disease, bronchopulmonary dysplasia, nephrotic syndrome, or immunosuppression. Adults, RSV produces influenza-like upper respiratory symptoms such as common cold, running nose, sore throat, and cough. Infections are common in overcrowded communities, military recruits. Recurrent infection is common in both children and adults but much milder, like common cold. Now, lab diagnosis. Antigen detection and direct identification of viral antigens in clinical samples is rapid and sensitive. Two methods are commonly used. Both use monoclonal antibodies specific for RSV. Direct immunofluorescence test detecting antigens on exfoliated cells, or ELISA detecting antigens in nasopharyngeal secretions. Virus isolations. HeLa and HEP2 are the most sensitive cell lines for RSV isolation. As RSV is extremely labile, freezing should be avoided and specimens should be processed immediately. A characteristic cytopathic effect, syncytium formation multinucleated giant cell, appears after 10 days. Hence, it is named as syncytial virus. Sensitivity of virus isolation or antigen detection are excellent in children, 80 to 95%, but low in adults. Molecular methods provide definitive diagnosis for RSV detection. Now, coming to RT-PCR, amplifying viral RNA such as nucleoprotein and gene has shown higher sensitivity and specificity, particularly in adults. Biofire film array respiratory panel test simultaneously 20 respiratory pathogens including RSV are there. Antibody detection. Various formats such as immunofluorescence and ELISA are available for antibody detection. Serum antibodies are of less diagnostic importance, rather they are the markers of prevalence of infection. Epidemiological significance is there. Epidemiology. Infection with RSV occurs worldwide. Seasonality, annual epidemics tend to occur following rainfall in winter and spring and last up to 5 months. Infection is not seen in summer. Age, RSV is a leading respiratory pathogen in children. Infants between the age of 6 weeks to 6 months of age are commonly affected, with a peak incidence at 2 months. Prevalence, about 70% of the infants are infected by 1 year of age and almost all by 2 years of age. Treatment of RSV infection. Unlike other respiratory viruses, specific antiviral drug is available for treatment of RSV. Ribavirin is the drug of choice indicated for severe infection in infants. However, its beneficial effect in older children and adults is also doubtful. It is administered as aerosol for 3 to 6 days. Oral ribavirin is not recommended. Supportive care is also needed, such as removal of secretion, administration of oxygen, bronchodilators, and ventilatory support. Immunoglobulin with high titers of antibody to RSV was used in past but was found ineffective and hence is not recommended currently. Human metapneumovirus. Human metapneumovirus was first reported in 2001, though the avian strains were prevalent since 1970s. They cause both upper and lower respiratory tract illnesses similar to those caused by RSV but less severe and tend to affect slightly older children. It may be the second most common cause next to RSV of lower respiratory infection in young children. They also cause respiratory disease in adults with underlying hematologic malignancies. Diagnosis RT-PCR is available to amplify the RNA extracted from respiratory specimens. Specific antigens in nasopharyngeal secretion can be detected by direct immunofluorescence test. Okay, so this completes the theory. Now let's discuss some questions. In early 2018, a 62-year-old debilitated man from Maharashtra presented with symptoms of severe upper respiratory tract infection. He had a history of exposure to a patient having similar conditions. Nasopharyngeal swab collected was sent to reference laboratory real-time PCR, which revealed that the causative agent was influenza A H1N1 virus. Okay, what's the mechanism of emergence? Pathogenesis, mode of transmission, lab diagnosis, an epidemiological impact of the recent 2018 epidemic produced by this causative agent, and the preventive measures, all that we can write. The pathogenesis and lab diagnosis of measles and measles virus infection we can write. Short note on mumps and H1N1 2009 pandemic flu. This also we can do. Now coming on to the multiple choice question. The most common cause of secondary bacterial pneumonia in patients with influenza virus is obviously Staphylococcus. Okay, now Ray's syndrome is a complication seen after all the following viral infections, except it is seen in all influenza and varicella zoster virus also causes Ray's syndrome, but measles does not. The trivalent vaccine for influenza includes all except includes H1N1, H5N1, and the influenza B strain. It does not include the H5N1. It includes H3N2, H1N1, and influenza B strains. Okay, which of the following statements about mumps is not correct? Bacterial parotitis, most common presentation, yes. Other salivary glands are never involved. They can be involved in some cases. Atypical mumps present as meningitis, yes. And incubation period is about 19 days. Is also correct. Which of the following statement concerning antigenic drift in influenza virus is correct? It results in major antigenic changes? No. It exhibited by influenza A virus? No. It is due to frame shift mutations? No. It occurs frequently than antigenic shift? Yes. It occurs much more frequently than antigenic shift. Which of the following paramyxovirius has the surface glycoprotein lacking hemagglutinin activity? It is the respiratory syncytial virus. Now, which of the following statement is not correct for the management of patient with category A influenza-like illness? Lab testing for H1N1 is not required. Treatment with oseltamivir is not required. Confine the patients at home. They are, of course, they are confined at home, and avoid contact with public and high-risk members of the community. It has, which is not correct. Treatment and lab diagnosis are not required. The treatment can be done if needed. Okay, symptomatic treatment. Now about the Global Influenza Surveillance and Response System (GISRS), which treatment is or are correct? It monitors the evolution of influenza virus. Yes. Provides recommendation in areas including lab diagnosis. Vaccine and treatment, yes. Serves as global alert mechanism for the emergence of influenza virus for pandemic potential, yes. So all the above are correct. According to CDC recommendation, the people with influenza-like illness remain at home until how much time after they are free of fever less than 100 degree Fahrenheit without the use of fever reducing medication at least for 24 hours they should be at home. Now, chemoprophylaxis for influenza is recommended for all situations except routine seasonal prophylaxis. No, this is not required. During outbreak situations, yes. For exposure to influenza case if not vaccinated or vaccinated recently, yes. And following exposure to influenza case if the individual is immunocompromised or like HIV. Okay, so this completes our chapter of influenza and all the myxovirus infections. Next, we'll be starting with coronavirus infection, including COVID-19. Okay, so like, share, subscribe. Thanks for watching.